Here's the second video preparing you for our upcoming lecture on bradycardias. This will focus on a clinical approach to dealing with gaps in otherwise regular-ish rhythms. Let's go back to the basic ECG approach at the top header of your ECG sheet. So we're scanning along the rhythm strip and we notice a break in R wave regularity, a gap. One way to approach the rhythm problem is to determine what's inside the gap. We'll address this on the next slide. Of course, we may not see a gap. The R waves might be regular, we might notice some P waves that look conducted, but then we get to a point where we see some consecutive P waves, which raises concern for at least one P wave that's not conducted to the ventricles. We've already discussed a little bit how to address that. But let's return to the gap, a break in R wave regularity. There are basically three possible gap contents, and they have limited associated differentials. If there's just one P wave in a moderate gap and it looks like it's conducted, you're probably dealing with sinus arrhythmia. If there's a bigger gap, consider sinus dysfunction. Also consider first degree AV block, but that's more about a gap between the P wave and the QRS. Two or more consecutive P waves will get most of our attention. This could be AV block versus premature atrial contractions. No P waves, and you should consider sinus node dysfunction, which we'll get to. Basically, sometimes the SA node stops generating impulses appropriately, or otherwise can't transmit them. A word on sinus dysfunction. Basically, the SA node, the heart's primary pacemaker, stops being able to do its job effectively. Sick sinus syndrome, which you've heard of, basically means someone's SA node isn't either making or effectively transmitting signals leading to the syndrome part. The patient has symptoms. Common ECG manifestations are, putting it very clinically, big gaps. Sometimes the kind of gaps that will make a med student ask, did that patient just die, when looking at the telestrip. Over half of patients with sick sinus syndrome develop tachybrady syndrome, where the big gaps and AFib alternate. A tachybrady rhythm strip will get a Cards Fellow's attention. Finally, sinus block, which is like second degree AV block, but the P wave disappears, not the QRS. We're going to save identifying this for the lecture, but note that unlike second degree AV block, it doesn't matter whether it's type 1 or type 2. You just need to identify that there's some block. In terms of AV block, supranodal causes associated with narrow complexes tend to be secondary to non-cardiac processes, vagally mediated, more reversible and transient, less associated with structural change, and thus less concerning, less likely to require intervention. On the other hand, infranodal AV block associated with wider complexes tends to be associated with primarily cardiac, non-vagally mediated, irreversible processes associated with structural change. In EM, our thinking is often informed by what's the most common potential cause of a presentation versus what's the most serious potential cause. You might be surprised to find out at this point that the most common cause of blocked P waves and interruption in sinus rhythm is not AV block, but is premature atrial contractions, or PACs. Still, the most common serious cause of interruptions in sinus rhythm associated with blocked P waves is AV block. Identifying complete heart block is the most surefire way to get cards interested in a patient. The patient is probably getting a permanent pacer unless they're suffering from coronary occlusion, in which case Cards has other ways to fix the problem. But patients get pacers for reasons other than AV block. If they're having symptoms and a correlation with bradycardia is demonstrated, then a pacer may well be in their future. As we just discussed, the sinus node can have problems generating impulses, just like the AV node can have problems transmitting them, and sinus node dysfunction plus symptoms often portends a pacer. Since you're in Vermont, if you're dealing with apparent infranodal block in an otherwise healthy person without any stigmata of ischemia in their presentation, it is Lyme until proven otherwise. Talk to cards, consider giving them ceftriaxone before you even do that. The patient will go to cards, who may place a temporary pacer to see if symptoms resolve with time and antibiotics. Know that when someone has a first-degree block with a PR of over 300, and that's pretty dramatic, IV antibiotics are indicated, as they are with any other AV block associated with Lyme. The issue of whether the Lyme patient gets a pacer leads to the question of who gets a pacer in general. Anytime you call a consultant, you should have some intervention in mind that can form the basis of your, quote, clinical question. And the ultimate intervention for bradycardia is a pacemaker. In general, symptomatic bradycardia without a clear reversible cause is a reason to pace someone. That said, supranodal causes usually won't get cards racing down to see the patient. Don't expect cards to be excited about symptomatic Mobitz 1 even if it ultimately needs a pacer. Sometimes cards does EP studies, exercise studies, a period of tele, etc. before pacing these patients. Even without symptoms though, cards will usually be interested in infranodal block, and it is generally appropriate to implant a pacer in these patients. Note again that infranodal block in the setting of ischemia often resolves with restored flow. When you're getting a history on a patient with bradycardia, you need to ask whether they've started any new drugs or are having issues adhering to their meds. You also need to ask about outdoor exposures, rashes, etc. Then you definitely need to check lights, and don't forget to check a thyroid cascade. I've caught multiple hypothyroid patients with symptomatic bradycardia. Don't forget to assess for ischemia when clinically appropriate. In summary, the above is an overview of my clinical approach to investigating blocked P waves. It's on your ECG sheet. Are there any conducted P waves? If so, then it's not complete heart block. Having identified blocked P waves, determine if the P waves look alike and are regularly spaced. If so, you're likely dealing with AV block. If the P waves are irregular and look different, then you're probably dealing with PACs. If the PR interval is lengthening until you get to the blocked beat, then you're likely dealing with Wenckebach. Grouped beating patterns in general, that is repeating groups of 2 or more R waves, are suspicious for Wenckebach conduction. If the PP intervals and the RR intervals are regular, then suspect infranodal block. Sometimes you have a conducted P wave alternating with a non-conducted P wave, and you accordingly can't tell whether there's PR prolongation. If the R wave is wide complex, assume that it's infranodal, but it's reasonable to discuss this with cards, particularly if the patient is having associated symptoms. But let's close this video by discussing the signs and symptoms principle for bradycardia. If you've got bradycardia on the ECG or tele, associated symptoms, and no clear evidence of reversible etiology, then it's reasonable to discuss a possible intervention with cardiology. That intervention could be discussing changing the patient's metoprolol dose, or discussing precursors to a pacer like an EP study, an admission for tele if they're not safe to go home, a Holter if you think they are. Just be sure to have worked up reversible causes, unless you've got a slam dunk pacer indication like complete heart block or tachybrady.